Hey everyone, welcome to Discussions with Dr. G. I'm Dr. G, your guide to not turning med passes into an episode of Grey's Anatomy. Minus the music montage, of course. Today we're diving into the stuff that saves your reputation and, more importantly, your clients. Medication safety and the essentials of getting those meds in the right spot with minimal drama. So let's start with technology. Electronic Medication Administration Records, EMARs for short. These have honestly changed the game. Gone are the days of chicken scratch handwriting and playing detective or psychic to decode which medication was actually given. Now it's all about real-time documentation, and I gotta admit, the system catches more than a few slip-ups before you even leave the med room. And don't forget the barcode medication administration. Now, scanning seems simple, right? Just beeps, scan, go. But if you've ever tried to scan a crushed pill in a souffle cup, you know it's not always instant magic. Still, that beep gives you a moment to pause and double check, like, are you about to give this client metoprolol or methylprednisolone? These look-alike, sound-alike drugs are a little sneaky. That reminds me, I remember a shift not too long ago. I went to give a med, scanned the barcode, and holy cow, the system shrieked at me. Well, not literally, but you know what I mean. Apparently, I'd grabbed a look-alike vial meant for a totally different patient, saved by the scanner. Can you imagine having to call that patient, explain why they got the wrong meds, and then fill out all the paperwork? No thanks. Technology's got my back, and hopefully yours too. But here's the kicker. Technology doesn't replace the fundamentals. You still got to follow the 10 rights of medication administration. I'm sure you've heard of them. Right patient, drug, dose, route, time, assessment, documentation, education, evaluation. And don't forget the right to refuse. It is a mouthful, yeah, but honestly, you skip one and you're inviting errors. And trust me, those challenges to safe administration, they're real. You've got interruptions every 30 seconds, pressure to move quickly, a stack of patients, and oh yeah, those look-alike files trying to trip you up. Let's not forget to mention those special patients that are unable to verbally verify who they are or when they were born, or who are in a place where name bands are just not worn. It's not just following the checklist. It's being present, using your clinical judgment, minimizing distractions, and when in doubt, double checking yourself or bringing in another nurse for that second pair of eyes. So let's move on and talk about all the wild and wonderful ways we actually give these meds. The variety keeps your day interesting, right? You've got your classics, oral tablets and subcutaneous injections. Sometimes you're pushing intramuscular into the deltoid, sometimes it's an IV direct, or even an epidural for pain relief right into the space along the spine. I mean, if a medicine was only about giving Tylenol orally, we'd all be out of a job. Then there's the fun stuff. Topical applications, patches, even intrathecal administration into the spinal canal if you want to really feel fancy. And with all these routes, you get all kinds of reactions. Most of the time, the effects are expected. Therapeutic even. Yep, this is why we gave the med. But then there are the side effects. Oh, those are like party crashers. They're generally not dangerous, just super annoying. You get the mild headaches or the drowsiness. The more concerning bit is the adverse effects. That's where allergic reactions, anaphylaxis, agranulocytosis, or even sepsis can sneak in. And let me tell you, it pays to be slightly paranoid after you give something unfamiliar. For instance, let's say you gave an intramuscular injection. Routine enough, right? A minute later, your client starts wheezing and breaking out in hives. You're thinking, okay, anaphylaxis drill time. You hit the call light, grab epinephrine, and thank goodness your monitoring pays off. That situation could have gone downhill real fast without your constant vigilance. The real trick is recognizing when a side effect is just a nuisance or that it's evolving into a big, bad adverse event. And yeah, I get it. Sometimes the difference between mild rash and start prepping for a code can be blurry. So never ignore patient complaints after giving a med, no matter how minor they sound. Oh, and keep your crash cart close. If you don't, you're going to wish you had. Bottom line, you have to be that extra set of eyes after each administration because let's face it, if something goes sideways, you're the one they look at for answers. Monitoring isn't just waiting around, it's keeping your clients safe. Period. Now, about error prevention and teamwork. If you thought medication safety was all about charting and scanning, think again. This is where the human element, autonomy, and good old communication skills come in clutch. First, let's talk medication reconciliation. Seriously, it's not just paperwork. It cuts down the risk of adverse effects big time. Make sure your current meds, your new orders, and home meds are all squared away without anything falling through the cracks. Ignore it, and you're rolling the dice on someone's kidney function. Whenever an error pops up, the best nurses don't hide it. They own it. There are classifications for these, by the way. Knowledge-based, rule-based, and activity-based errors. Like maybe you understood the order, right? That's knowledge. Ignored a best practice. That would be a rule. Or just got distracted during administration. That's the activity. And with just culture, the focus is on learning, not blame. Doesn't mean it's fun to admit you messed up, but it is way safer for the client. Client education is another tool. Explain the meds, check for understanding, and don't just toss the handouts on the bedside table and leave. Follow-up is crucial. It can be incredibly frustrating to have given the client instructions and then found the teaching sheet crumbled beside their lunch tray. Trust me, this happens all the time. Turns out, repeating and checking for understanding really is the key. And you can't forget about the interprofessional collaboration. There was this one time, a sentinel event almost waiting to happen. A client came in with a laundry list of allergies and an antibiotic order that, in hindsight, should have screamed bad idea. Thanks to ISBARR communication, identifying oneself, describing quickly the situation in the background, providing a brief and focused assessment, giving a recommendation, and then reviewing the provider's response out loud. We, the nurse, pharmacist, and provider, all hashed it out and caught the issue before med admin. Total win for teamwork. At the end of the day, it's not just about your charting or your MedPass technique. It's a team effort. Strong education, open communication, and maintaining that slightly neurotic attention to detail. That's what keeps our patients out of trouble and us off the front page of the local news. All right, folks, that's it for this episode. Make sure you come back next time. We're definitely not running out of pharmacology drama in the real world. Stay safe, double check those meds, and don't be shy about asking questions. See you next time.